Well, welcome in everybody and good afternoon. Welcome to today's Pediatric Readiness Recognition Programs Collaborative session. This is our 9th session, so thank you all for joining us. Before we get started with today's session, we would like to acknowledge that the Pediatric Pandemic Network and the EMS for Children Innovation and Improvement Center are supported by the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official view of, nor an endorsement by HRSA, HHS, or the U.S. government. And as a reminder, our session is being recorded and will be posted to the EIC's website along with today's presentation. And as always, we look forward to having an interactive session with you all, so please feel free to raise your hand or come off mute throughout today's presentation. And during today's session, we would like to reflect on our journey thus far and what comes next. We look forward to wrapping up our discussion on the recommended minimum criteria for recognition, as well as our discussion on verification. So to get started, we're going to look at where we started. If you'll recall, the goal of the PRRPC, or the Pediatric Readiness Recognition Programs Collaborative, is to support the state partnership program managers in developing both ED and EMS recognition programs that align with the EMSC performance measures, identifying best practices for criteria, application, verification, process, and recognition, promoting the creation and expansion of pediatric recognition programs that align with the National Pediatric Readiness Standards to enhance pediatric emergency care. And if we look all the way back to August of last year, when our state partnership program managers completed an environmental scan for us, we gained a better understanding of the current state of recognition programs at that time. And if you had an existing program back in August, you were asked to identify what criteria was included in your ED recognition. And these are the results that we found. We identified that at least one PEC was a criteria in 95% of the recognition programs at that time. And disaster plans addressing the needs of children were seen in 91% of those recognition programs. And you can see the criteria that we asked about at that time in the corresponding percentages in which those were included in your recognition programs. Again, this is based on the August 2023 results from the environmental scan. Some of the other questions that we asked back in August were if site visits were part of your verification process. 95% of the existing recognition programs responded that verification was a part of that process. When asked if that included in-person only or in-person and virtual, we saw that 12 of those states with current recognition programs at the time did implement in both in-person and virtual recognition verification visits. In addition, we asked about the structure of your recognition program, whether it was one level of recognition, 2, 3, or 4. And we look at this map, you're seeing both solid colors are established recognition programs, and those that are the lines are a little bit tricky to see on this display. I can share this image a different way if you're interested in seeing, but this is as of August again. If those were not formal recognition programs, how they were anticipating their program to be structured. 26% of ED recognition programs were going to be single levels of recognition. We did see that having 2 levels of recognition were 9% of the states that responded. And for 3 levels, 31% of our respondents indicated that's how their program is structured or would be structured. So that's the bulk of our responses and the knowledge that we know about recognition programs at that time. And at that time, 30% indicated that they were unsure of how the recognition program would be structured. That's a little bit of what we knew about ED recognition programs. We looked at pre-hospital recognition programs. We asked a similar question to the existing recognition programs. This is a smaller sample size. There are fewer pre-hospital recognition programs that were in existence in August of last year. We asked the same question of what criteria was currently within their recognition programs. You can see there, 100% of those recognition programs that existed in August indicated that they did have a designated PEC and processes for ongoing pediatric specific education. Similarly, we asked you all if you had a pre-hospital recognition program, if site visits were a part of your verification process. 3 of those states that had recognition programs at the time indicated that they did perform virtual or in-person site visits as a part of the verification process. We looked at the structure of pre-hospital recognition programs back in August. We did see that the large majority of those recognition programs are single levels of recognition. 52% of the respondents indicated that their program is or would be a single level of recognition. Again, some that indicated it'd be 2, 3, and 5 levels of recognition for some, but again, 52% indicating it would be a single level of recognition. That's a little bit of what we were able to learn about our existing recognition programs through our environmental scan back in August of last year. So thank you all for responding to that survey and helping us have a better understanding. That's where we all started. And then you joined us in Austin for our all grantee meeting, where we had a chance to meet you all and sort of launch our collaborative. And where we went from there was really influenced by some news media and some current events. I'm going to hand it over to Kate to remind us a little bit of what we saw in the Wall Street Journal.
Sure. Thanks, Casey. I mean, I would just say that this just created context for the work that we're doing. And this was not the first time that pediatric readiness or recognition programs have made it into the news. In fact, we've seen it in the news many times over the last 20 years in U.S. News and World Report, in the Wall Street Journal about 10 years ago, and then again now. So this was certainly not the first time that the work of all of you, the work of the EMS for Children program more broadly, and the concept of pediatric readiness had made its way into the public space and really provided an opportunity not only for our national partners and stakeholders to see the impact of this work and the growing momentum of it, but also I think for us as a collective program to reflect on the progress that we've made thus far. As you all know, I think the Wall Street Journal tends to be a little bit dramatic in their reporting. And so, of course, the title here was intended to elicit an emotional response and grab attention that children are dying in ill-prepared emergency rooms across America. And this is despite the fact that we've actually made a tremendous amount of work and a tremendous amount of progress. And this is not intended to be, a mark against us as a program. I think instead it actually speaks to the growing awareness and the importance of this work. But one of the subsequent articles that had come out of this, and one of the issues that came out of this was we started getting a lot of questions from the media, radio shows, TV shows, the news, the public of what do we tell parents? And really coming to us as a program and saying, well, if children are dying and you're the experts in emergency care, where do we send children? What do we tell them? Where do they find the most appropriate EDs? And thus, begets the importance of these pediatric recognition programs. Certainly for EDs, because there's sometimes a choice, maybe perhaps a little bit less so in EMS in terms of how to direct parents, because EMS exists within the community and we don't often have a choice of who comes when we call 911. But what really came out of this too was an effort that was driven by the Wall Street Journal, not by us, where they provided a map of emergency departments that they said were pediatric ready. And some of this maybe came from you all directly. Some of it came from them saying, oh, these are children's hospitals or these are trauma centers. And so by definition, they believed that meant that they were pediatric ready, which was unfortunately not true. But when families and parents and pediatricians read this, they see, oh, here's where there's a pediatric ready facility and I'm going to go there. And what we now know, of course, from all the data is that pediatric readiness does truly impart a potential survival benefit. So by and large, this map was wholly incorrect. We did try our best to get them to correct this information. And we're unsuccessful. But I think this provided a platform for us to control the story and begin to take hold of that. and particularly in the midst of launching this pediatric readiness recognition program, and within the framing that the public is now aware of the need, and they're aware of the work we're doing, and now we have a responsibility to really do this well. So if you could go to the next slide, please, Casey. We talked about this early on. We talked about some of the takeaways, and there were certainly some truths that were uncovered. I'm not going to go through all of those, but what we do know is that the importance of our work really cannot be underestimated. We do know that in the healthcare system, resources may be limited, but even so, we now know there are manuscripts that have come out related to the cost of pediatric readiness, and we know it's really not an enormous ask. It's minimal relative to the potential benefit. We witness every day how our team is growing and how we're bringing more and more partners to the table, more and more EDs. And with that, our voice is getting louder, and pediatric recognition will become a success because of our ongoing and persistent efforts. If you could go to the next slide, please, Casey. I think some of the other key takeaways that we highlighted is that, when we look back at the starting point of this collaborative, is, as you saw from Casey's slides, at the beginning of this, when we looked at recognition programs on the ED side, there was not one single criterion within the pediatric readiness guidelines that was consistent across all of the programs that existed. And I think what we saw is that if we don't have consistency in criteria, even minimum criteria, then it kind of discounts or discredits the value that we potentially bring to the field, because we're saying there are variable standards when in fact there are national standards. So that was really why I think we all within the EMSC program collectively felt the need to move towards standardized criteria. And I know that this at times felt frustrating, or at times felt challenging, but I appreciate the effort that you guys put in to get us to consensus around a minimum set of standards and criteria, because I think it will bring real value and credit to the EMSC program as we look, across states and say, no, this is the minimum standard. We do know that because there is more public awareness of this, that responsibility is really beginning to shift to us as we launch these programs, that we really are standing behind the criteria that we are using. And we're saying that this is meaningful and it's valuable, and it'll bring improved care to the pediatric population. And in fact, as we've talked about, hospitals and EMS agencies are really looking to us to say, what should we be doing? And so the more that we align with those national standards, as we have attempted to do with minimum criteria, and certainly with the stretch goals as well, really provides that backing that we need within our programs. And then, I will say, and I just mentioned this, emergency care is really taken for granted. Unfortunately, with EMS, there's not really a choice. When you call 911, you get the service that's in your community. But recognition, I think, really will begin to be used much more broadly by the healthcare community, by EMS agencies, and perhaps, as we're beginning to see, by the public, to really identify the most appropriate destination for children. And so I think it's important to have awareness that we collectively, the EMSC program, but most importantly, I think each of you are the change agents that are really setting the standards, setting the backbone for transforming our emergency care systems. And I know this is not a small undertaking, but we have made enormous strides, and I'm really excited about where we're going. So thank you for putting up with us over the last few months as we worked through this, and really excited for where we are today. Next slide, please, Casey. So the consensus activity was really an attempt to make sure that we, the EMSC State Partnership Program, was in consensus of what was achievable, what was feasible, and what was valuable to bring back to the community as meaningful change. and really wanted to make sure that this comes from all of you and not as a directive. And so it was important that we did it in this way of trying to bring all of the states together. Some of you chose to work with your technical advisory councils or your EMS advisory committees, and we are happy that many of you did that. Certainly wasn't a requirement. Regardless, we wanted to make sure that each state and or territory had an equal voice, and so there was one vote given per. Next slide, please, Casey. So the whole consensus process, you'll remember we kind of walked through a series of rounds. This is a standard Delphi process. Really, the goal is to make sure that there's an understanding of each of the criteria and make sure that there's alignment. So as I think you all heard last time, there were a few items that came up with a really broad range, meaning some people rated it very highly and some people rated it quite low. And because of that, we revisited at least one criterion, which we'll talk about in just a second, because it meant when we see that big range, it means that we don't have consensus, right? And that's why it was revisited. But it started with bringing everyone together, started with trying to say, can we get to a single set of standards? We went through round one, we analyzed the results, we looked at it, we looked at the variability of scores. We went into round two, looked at that feedback, and we slowly sort of narrowed the field of what was most important to move forward with. And that is where we landed today. And so if you can go to one more slide, please, Casey. So these criteria are really intended to strengthen our program, and I think they not only provide that backbone for high quality care, of course, but they also solidify the voice of the EMSC state partnership programs and of the states and territories. It is consensus driven. This is the minimum. Our goal, of course, is to try to move towards the full set of pediatric readiness standards as suggested by the national partnering and co-authoring organizations. But it does serve as, to the extent available, an evidence-based starting point, and allows you to take that back to your states and territories, adopt it, adapt it, expand it, and hopefully grow engagement over time. So that's where we are today. And I think with that, Casey, I will turn it back to you.
Thank you. So do you want to provide an update on the results of the fourth round that we sent out after last month's meeting? So if you recall, we reintroduced and asked you to consider the inclusion of quality improvement activities. Through some editing, the criteria that was proposed was to incorporate pediatrics into quality improvement activities. We did receive responses from 31 states. The average score for importance was 4.4. The average score for feasibility was 4.1 among those 31 states. And the overall average was 4.2. We did have a range of 2, with our highest score being a 5 and our lowest score being a 3. As we discussed when we reintroduced this criteria, if it did not have an overall average score of 4.4 or higher, it would not be considered as the recommended minimum criteria. We do want to, again, take a moment to thank you all for contributing to this extra round and participating in that survey. Again, we had 31 states respond. Many more individuals responded to that, but again, the average of only 1 per state was taken into consideration. So those are the results of our fourth round. Are there any questions or comments about that round and the results that we have here? What that might mean? So with that,
sorry, Keith, can I just say, so it will remain a stretch goal, which is where it was originally positioned, but based on the votes will not be included as the minimum criteria.
So you can see that here, there are 6 criteria through our consensus activity that we've come to recommend as minimum criteria. And then we've placed the other items into stretch category, which can be included in other levels of recognition or in your state's minimum level of recognition depending on what fits your state's needs. So here we have our 6 recommended minimum criteria for ED recognition programs. Pause here, take any questions.
I'm concerned on your stretch criteria. I guess I really like the verbiage where it said incorporate pediatrics into your QI plan. That makes it sound like they have to have a separate pediatric QI plan. Is there any way to, or would there be any consideration for editing the stretch criteria to what we had previously used?
Yeah, I think that's really just a slide editing oversight on my part, but we can make sure that reflects the verbiage discussed during the last meeting.
Thank you.
Mm-hmm. Thank you for pointing it out. All right. And then any other questions about ED criteria before I share the pre-hospital? Based on past discussion related to pre-hospital recommended minimum criteria, there are 3 recommended criteria to be considered for your minimum recognition level. We have those here, and then the remainder of the criteria has been placed into a stretch column for your consideration. Any comments or questions related to the pre-hospital criteria?
I'm wondering, it says for the stretch for patient and medication safety that it's based on agency's licensing or certification level. I know in Oregon, it's not based on the agency, it would be based on the provider licensing level. So they each have varying levels of orientation and education around that.
Rachel, can you clarify if their state does agency quote ambulance licensing, like, and if that licensing process for the state includes what the agency does as a scope of practice?
I don't know if I understand your question. Can you rephrase it?
So you're talking about licensing really being at the provider level, correct?
Well, both providers and agencies are licensed in the state. Is that what you're
Right.
asking?
Yes, yeah. But you're saying that the equipment is not under the.
No, I'm talking about
your...
patient and medication safety. It says
Mm-hmm.
receive regular training on safe medication dosing for children based on agency's licensing or certification level. So it would be not based on the agency, but based on the provider.
Yeah, I think we can say, you know, clinician scope of practice.
That's good. Thanks.
See, and I would have a little bit of concern with that. Because kind of where you were going, Doc, is if an agency is only licensed at the BLS level, but they may have some providers on that agency that are paramedics, they still can't operate at that paramedic level on that agency because of that agency ceiling. So I guess that'd been my only concern with changing it to there, is because it goes back to we're measuring the agency, not the individual provider.
I wonder if it is really kind of a policy that requires some, you know, assessment or regular training of clinician providers to provide care according to the agency level of licensed care provision. I know that's a complicated, I didn't say that well at all, but I think what we're really getting at here in the quote term requires is really, does the agency have some program, some process, or some policy written to clarify, you know, that there's ongoing, you know, work to ensure medication safety is practiced.
Perhaps it could be more general, like keeping most of what's in the front end of that sentence and take out the part in parentheses, like you just don't need it.
I could feel comfortable with that, yes.
See, Mark has his hand raised.
Sorry, I didn't know if you wanted me to talk.
Right.
I was just going to say that it almost seems like those are two separate issues. Is that, you know, you may have an agency that's licensed at a BLS level. They should have a policy for whatever medications are within the scope of practice for BLS care. But even if you're a paramedic working for a BLS service, we still require them to relicense at the paramedic level. We don't say, oh, you're only with a BLS service, you don't have to do paramedic level education. So I wonder if it could be kind of split out, is that agencies would have a policy or training based on their agency licensure certification, and personnel would also do training based on their licensure or certification, because it's potentially two separate issues. Just a thought.
You, Mark?
I think we're now getting way too detailed, and I mean, our pre-hospital providers already have to do training to keep up their license and stuff. I'm going to go back to we're recognizing the agency, not the individual. And for the most part, I agree with my colleagues that we have a lot of paramedics that work in agencies, usually in their communities that are basic level agencies, but they already know that they're going to have to do training at the paramedic level. This is for the agency, not the individual provider.
Thank you. I'm seeing some other comments in the chat as well. I don't know, Morgan, yours is just the first one I saw here. If you want to come off mute and expand a bit more on your comment.
I was just suggesting removal of the words on agencies. So it's based on, or just the word agencies. It's based on licensing or certification level, and then the states could determine how that's works in their state.
Make it easy enough edit. Appreciate all of your feedback on this, everyone. And these are what we've considered to be stretch criteria. So elements that can be in higher levels of recognition or at your state's minimum level of recognition, and are meant to be a starting place for you to go back to your advisory committee and begin having that conversation of how you would like to adapt and adopt it into your recognition program. Any other comments or questions about the criteria before we move on to what's next?
On the bottom there, it says presence of field triage algorithm. I'm wondering if you mean use of or something else, because presence of, I don't quite understand what that means.
More in lines of just having a field triage algorithm is maybe a better.
Is utilize the right verb? Or implement?
Yeah, I mean, it's one thing to have it in a binder, it's another thing to use it. So, yeah, just a thought.
Thank you.
Casey, there was a question in the chat for The recommended minimum criteria, the second one, pre-hospital personnel are oriented and assessed. And she wanted to know what we mean by assessed on the second criteria. And Emily, if you want to say anything about that, you can come off mute.
So we're finding that one in the chat for me. I don't know.
Yeah, I didn't have anything else to say on that. I just was confused about what and assessed means. Are we saying that they need to be tested on like a scavenger hunt on the location of the equipment? Or they need to be assessed that they know how to use the equipment?
So Emily, I think it could be asked differently. You could say, does the agency assess whether providers know where the equipment is? And is that something that you do regularly? If you wanted to, during a verification visit, you could take a crew and say, show me where, XYZ is. But I don't think that was the intent, wasn't for the MSC state partnership managers to actually request that a scavenger hunt be performed like during the visit or anything like that. But that would be taking it above and beyond if you chose to do that.
But the way this criteria is written, was the first thing that you said, that we are requiring the agency to assess and determine that their personnel know where the location is of the equipment?
Yeah, and you could ask it in a way of, how do you orient your crews to the location of equipment and assess like their knowledge or capabilities relative to that? And so it might not be a checklist of every provider that they have. I mean, you could say, show me all the providers that have gone through that training. But yes, it would be asking them if they do that.
And
Okay.
again, the criteria as exactly written is not necessarily the point. It's the spirit of the criteria that you can then write in your own criteria, should you choose, in a way that makes sense for your program and what your program can feasibly do assessments of.
Great question. Thank you, Emily. All right. If there are any other questions related to the criteria, feel free to reach out to us. You can either email me and I can share it with the PRRPC team, or email us at the collaboratives at emsc.improvement. Or emsc@improvement.center. I think that's a great comment in the chat from Mark, but maybe we'll save that for our discussion in a little bit about verification. I don't know, Julie, if you want to flag that one for later. All right. So thank you all for your contributions to our consensus activity. We're excited to talk about what's next. So with your dedication and your contributions to this consensus activity, as participants in this collaborative, you and your teams have come to consensus on what minimum criteria could be recommended for both ED and pre-hospital pediatric readiness recognition programs. And over the coming weeks, the PRRPC team will finalize a set of resources related to the recommended minimum criteria. And there'll be more on this coming. But if there is anything specific that you feel would be beneficial to you and your state or territory's recognition program related to this, feel free to reach out to us, and we would be happy to work with you on that or begin tailoring resources we have to share them with you and to meet your needs. And as we are excited to enter this new phase of the collaborative, we look forward to providing opportunities to hear from our participants. You will have a space and time to begin to hear from one another and learn from each other's experiences. The time for participants to ask questions of one another, and we hope to hear from all participants as we progress through the next several months. The participating states will be asked to sign up for a brief update during one of the following 5 sessions. I will be emailing this to the state partnership program managers, and they'll be receiving additional information on this process, including a template, a link to sign up, and some other notes on what that might look like. But we anticipate these sessions will be very interactive, and we look forward to hearing about the amazing work and having robust discussions around it. It's very informal, a chance to hear about the work you're doing or the work you plan on doing, and receiving input from one another. So we are excited to begin that stage of the collaborative and hear from you all about that. In addition to the resources related to the recommended minimum criteria, we look forward to working with you all on compiling and sharing information related to the application process, as we've discussed in previous sessions, and bringing the communications team back to share the work that they've been working on related to recognition programs, and to helping to address any additional needs that might arise as we continue to discuss this process of pediatric readiness recognition programs. Now, that was a lot, and some changes are coming, and we're excited for that. We do want to make sure that everyone is ready for that transition. And if you have any questions, we'd be happy to address them now or by email later. Again, I will be sending out more information and the details of that process of signing up and some templates over the next couple of days. So I will pause there and see if I can help address any questions or concerns about that process of hearing from you all.
Did you say that you're going to be having us split up into 5 groups, or
The next 5 sessions.
the next 5? So we won't be hearing about what other people are doing if we're only in one session, or like, I'm just not.
Yeah,
I'm not
so
clear.
we have 5 remaining collaborative sessions. The collaborative was set from September of last year to December of this year. So we have 5 remaining sessions, and we hope to have state partnership program managers sign up for 1 session over the next 1 time slot in the next 5 sessions to share an update. You are obviously invited to join all the remaining sessions, so you have a chance to hear from everybody. But to provide time for everybody, we'll expect to hear from 9 to 12 state partnership program managers a meeting. Hopefully I didn't make that too intersected and confusing, but you will have a chance to hear from everybody. What other questions are there? Well, if you do have further questions, feel free to reach out, and I will be sending those details here shortly. So you all have helped over the last several months in this consensus-driven, evidence-based starting point in developing that for recognition programs to begin developing their recognition criteria around. So with the recommended minimum criteria, programs can adapt and adopt these into their recognition program. We began discussing the important role that communication has in branding and raising awareness for recognition programs, as well as the process of accepting applications. We look forward to continuing our discussion today on verification. And on that note, I will hand it over to Julie so we can wrap up that discussion from last month.
Hi, everybody. Checking the chat real quick. So last month we got to talk and hear from Nicolena from Colorado and Sam from Texas about their verification programs or their verification process within their recognition programs. And we started the conversation, but we didn't finish it. We wanted to talk a little bit more. We've had several questions come in from email that we have ready for Nicolena. Sam is unable to join us today, so we've got Nicolena. But we also want to hear from a lot of you as well. So Colorado has an ED recognition program, but they do not have their pre-hospital recognition program yet. So whether you have everybody on the call, an ED or pre-hospital, we want this to be a very interactive conversation. So the last time when we did have Nicolena and Sam on here, we talked about their design of their verification processes. We talked about who was involved in those, how they went out on site visits, whether it was virtual or on site, maybe it was hybrid. If you'll remember, Colorado has, Nicolena will go out, or at least one person will go out to be in person, but then they'll have some of the other committee members will join via Zoom on those verification visits. And then same for Sam, he does a lot of hybrid model. They did not charge, there was no verification charge. And then we also in that talked about the deficiencies. So how were deficiencies identified and how were they addressed? There were, I think, in both cases, they would follow up with them, they would identify the deficiencies, and then they would follow up with them, or they would review to make sure that everybody was on the same page. And sometimes people were not on the same page, one side or the other. But then the program managers would work with the sites to figure things out and then follow up to make sure everything was corrected. So that recap, Nicolena, I'm going to throw it over to you. Does that sound accurate for your part, for Colorado?
Yeah, yes, it does.
Awesome. So in that, before we move on to today's questions and the further questions, let's revisit the on-site versus virtual, because there was a comment from Mark in the chat that verification visits for all agencies, that would really mean that you wouldn't have any other work. You wouldn't have time for any other work. So Nicolena, I'm going to start with you. How do you address that as far as you've got all these hospitals that, or is that an issue? Do you have so many applications that you can't make them? And how do you juggle that? And how do you schedule those? And then I also want to hear, after that, I want to hear from others. So be thinking, and others think, I would like you to come off mute and talk about your program as well. So Nicolena, how would you, how do you address that?
Yeah, and I think I should probably clarify that the Colorado program is based out of the University of Colorado School of Medicine. And so we are not in the state EMS office, although we do work alongside them. Colorado is also different in that I hear many of my other colleagues talk about the injury prevention programs they work, the safe sleep, some of the regulatory work that they do. We have mechanisms for all of that in Colorado. So for example, we don't do pediatric SAVE awards because our advocacy group at the state level does that. We don't do a lot of injury prevention because our injury prevention groups across the state are very active. And so we rely on them as partners to host a lot of those activities. And so I want to caveat that up front and say our program's a little bit different in the capacity in which we have to be able to go out and do these site visits. And I recognize that not all states may have that capacity because of time, travel, distance, and weather. So one of the things that we do up front is that we have our website, which we are working on based on some feedback from our applicants and our previously verified facilities. One of the things that we've realized is that to offload some of the work from myself, we've needed to create more resources on the website that are very obvious, to the point that we're going to have a button that says, start here. Because all of those resources are there and they look very clear to us, But when we talk with different hospitals, they say, I just don't even know where to start. I've seen your application, I've seen your checklist. Is this it? And the answer is yes, and they're on the right track, but we haven't made it crystal clear to them that that is where they need to go. And I think that's important to remember, especially as you work with rural facilities, because oftentimes the trauma program manager may be also one of the lead nurses in the ER who might be covering someone else's job duties because of turnover. And so their capacity to be able to hunt down these details is not there. And so I've taken a lot from James Clear's book, Atomic Habits. He talks in there about how people use websites and how to find it, and that if we make people look for the answers, they won't go find it or they can't go find it. So as you're looking to, use your resources, I would encourage you to make it super obvious and ask someone who's not in your industry, who really doesn't understand what you do, to go to your website and report back to you. Could I find the application? Was it terribly clear for us? So that's one way we're trying to increase capacity. We're also hosting office hours once a month. So just open office hours. I set up a Zoom registration system, super easy, took me about 5 minutes. And I'm there for an hour once a month. Anybody can pop on and ask any questions. And this is cutting down on a lot of the time that I was previously dedicating to meeting with hospitals one-on-one to walk them through the process. So more opportunities for people to come in and touch base. The other thing that we do that I think helps consolidate some of our efforts is that once an application, which is not actually an application, it's more of a data collection. This is the name of our facility. Yes, we're going to participate. Here's some statistical information about us. Then we have that in REDCap, so they can go in and they can update it at any point in time. Once they hit submit, I review that, and if there's any areas where they say, and we have it listed as if this is done, we're working on it, or need more resources, or no. So just 3 options: yes, we're working on it, and no. I send them resources for anything other than yes. And it basically is just links back to our website. So I'm not going out and finding anything for them. It's a resource that already exists. And then once they button up all the areas on the application and check them all yes, I have a meeting with them that can last anywhere between 15 minutes to an hour, identifying the next steps of the process, which really cuts down on the email back and forth between me and a hospital applicant. We've recently changed it up to say that we are going to request everything in the policy section. We're going to request an electronic copy up front so that we can review it in advance. Because what we were finding is that we didn't have time on the day that we met with them to review all those policies. And so we wanted to offer a better opportunity to review that. And then taking a look at the checklist and the policies, if there's any deficiencies found, I try to help the applicant correct it first. So that way, when we get to the one-on-one, the verification, whether it's virtual or in person, that we are there just to try to see what they're doing. And it's amazing the things that we have found hospitals doing to help take care of their kids. One of them was so simple as one of the hospitals changed all the language around weighing patients in kilograms to here we weigh our patients in kilos. So everywhere there was a poster that identified kilos or pounds to kilos, it was actually inverse. It was kilos to pounds. And their scale that if they couldn't convert, it had a button on it that says, here we weigh our patients in kilos. And so it was a very positive shift in the, no, don't do that. And so we've been sharing that with our facilities. Also, one of our facilities was identifying kids by Broslow color on their hospital wristbands. They didn't have the financial capacity to buy new wristbands, so they were using stickers. And it's just little innovations like that, that when we go to these facilities and see them and get permission then to share that back out, I think that whenever you have the opportunity to go meet in person with your facility or even virtually, it is a huge benefit. Just because there are things that you will learn and see that you probably can't pick up just from a paper application. I also think it's a real opportunity for facilities that are facing a little bit of pushback from maybe leadership or their teams to say, why are you spending your money and efforts this way? Is that when they bring their team in and our folks come in and we ask them these questions, and some of them are fairly poignant about how they're doing things or the way in which they chose to do this, they really get to shine in front of their hospital leadership, and it reinforces why they're doing it. And I recognize that's not going to be something that every state partnership program can do. But one of the things that we have done that's helped expedite our process is partnering with our trauma team at the state. And we have modeled our process after theirs, which has worked great because all of the hospitals are familiar with the state's trauma process. So it looks and feels very similar. And some of our spreadsheets are even copied from their spreadsheets, and then we change the language on them and the formatting. But it's a process that everybody in the state understands. And so it seems to work really well that way. I think I kind of went down a little bit of a rabbit hole. Did I answer your question, Julie?
You answered mine, absolutely. I think that was a great synopsis of how to make it more doable, to make those on-site visits not so strenuous, cumbersome, and not so time consuming. So I think those are some really good points.
Yeah, and our state's trauma process has really ramped up its utilization of electronic reporting for applications. And I'm trying to model some of that work in our application. We use REDCap. And so, for example, the state traumas application, they can submit all of this documentation. It's very streamlined, then it goes out to everyone. And so I'm trying to work in how do we implement some of that within our process, so it's not a secondary ask for, okay, you did this, now that you've done that, we need you to hand us this. And so it's, we're still, I will be honest, it feels like a little bit in the pilot phase, but I think it's just our willingness to learn from what we're doing and tweak the process.
Kathleen, see your hand raised.
Yeah, thank you, Nicolena. That was such a beautiful summary of the work that you lead here in Colorado. And the other thing is we have like 23 applications kind of in the hopper right now, and we have 6 facilities verified. And I would say from time of application to time of verification, it's about 6 months just to kind of get a visit on the books, get people organized. From time of interest to time of verification, I would say is maybe a year. Nicolena, is that a fair?
Yeah, and I would say that's probably a fair assessment of the timeline, because people will reach out and say, where can I find this information? And I try to get them to fill out the application so I can get their contact information and stay in communication. And a lot of times then I don't hear from them until they submit the application, and they're 90% of the way there.
So it's not something that happens overnight for us. And I do think that as more facilities come on board and are verified, we have to begin the strategy of how do we do re-verification? How do we start to go back out to facilities a couple of years after they've been verified? And so we're still in the early stages of thinking that through.
One thing that has, sorry, just Julie, one thing that has really helped us is our trauma verification process. Because we are non-regulatory, and the state of Colorado has said this is going to be a non-regulatory process, this is 100% voluntary, it has made, I think, some of the work a little bit more digestible to our facilities. When trauma says, oh, by the way, you have a year until your trauma application's due, and don't forget all of these other areas. Did you know that EMS for Children has a lot of these policies, these tools in place that actually go towards your trauma application? And so when we had a trauma site visit for one of our facilities last summer, and they followed up with me, and they're like, we verified 3 sites that day. The facility that had done the pediatric readiness was night and day compared to the other facilities. And we've started sharing that. And so partnering with those other organizations who can, share the work that you have, literally the work that you can, make it easier for them to do it, but also let folks know that this does, help in other ways. There's crosswalking between the state's application, between ACS, and so it's not just this little effort over here. It goes towards that. So I would encourage you that if you haven't already met the folks who verify your or who do a trauma designation or verify your facilities, these are people that I think is worth meeting and letting them know what resources you have, because they need those resources for the hospitals, but it also just really helps spread the word. And if you're non-regulatory, it's kind of like you're Switzerland. You're here, you're just here to provide resources. You're neutral. And so I think that has also really helped. I get a lot of referrals from our trauma program.
Has anybody on the call, well, on either side, ED or pre-hospital, do you have anything to add? But that's what I was really going to ask, is anybody on the call have pre-hospital programs that they have an issue with going out to do site visits? Or do they have any tips, tricks, best practices?
I don't want to throw Vicki Peterson under the bus, but I've been following some of the work that she's been doing in Iowa because of how she's utilized the the ambulance licensing inspections. And so, I'm looking to follow her lead on some of that in Colorado, just because our geographical diversity is going to be such that I don't know how we will get out to all of these sites. So using both a voluntary process of identifying things that they have in place and then the actual ambulance inspections. So Vicki's doing some interesting work that we've been looking at.
Hey friends, yeah, that's my plan. I guess I'm sort of waiting to finalize my pre-hospital program until I figure out how all this stuff turns out, so I don't have to redo it. But yeah, the only way, having more than 700 agencies, there's no way. I struggle with site visits for my 117 hospitals. That's a ton, and so I can't do site visits. So that is what I've determined, is I'm going to have my EMS evaluators fulfill the site visit aspect of it with the checklist and guidance that I provide. And I think it's a great solution, and I appreciate their willingness to do that.
So using other resources. Nice. Mark, I saw your comment and you said, I am having successes in different ways. Do you want to talk about some of those successes and how you're getting those successes?
I guess in general, I mean, in terms of the whole program, I look at many of the aspects that we do for the EMSC grant, and, it's a comprehensive program. And so, I look at some of the efforts that I do at my state level collaboratively with disaster planning. I have a physician that's working through my AAP. I have weekly meetings with the executive director of AAP in my state. And, I guess I don't feel like showing up in an emergency department and walking up to a physician and saying, show me where your pediatric oral airways are, is a great use of either of our times. I have a trust level in them as a professional that if they tell me they have it, they have it. My goal is to encourage them to have it. And I have lots of meetings, discussions, emails, phone conversations. But for me to get in a car and drive 7 hours to the northern part of Maine is going to involve 2 nights of hotel stay, and for a 15-minute visit, is not, the juice isn't worth the squeeze on that. And I guess I struggle. I can't empower my advisory committee or anybody that works for me because they're doing business on behalf of the state at that point, which makes them a state employee. That does not work in my state. And I can't do those things. So when we start, I mean, I appreciate all the different suggestions and I appreciate the different approaches, and certainly there's ways to do it, but I'd rather have those people submit documents and submit their verification, and that works for me. I have a trust in them. I don't ask for prove that you went to medical school, that you can be a physician PEC. I don't ask for that. And I guess how deep we go and how nuanced we go starts in my state to really challenge with regulatory that we don't have over hospitals. And I struggle with that. So, my successes are encouraging and supporting and finding a comfortable level. The term I always use with hospitals is what is comfortable for your hospital, both staffing and financially. And I've never had any of them be like, please come here. If I said I'm going to come there, that would stress them out. They wouldn't know what to do with that, and it would hinder my process and delay any recognition. So I guess it's, maybe Maine's just different than everybody else, but
Hey, Mark, can I ask a question? Do you guys do any onsets for the original EMS provider agency licensing?
I'm sorry, you cut out at the beginning on my end.
Sorry, does the state do on-site visits for EMS provider agency licensing?
We used to. We stopped before COVID because we don't have the staffing to achieve it anymore. So the only visits we do is if there is a formal complaint, and then we might go out. So it is based on that.
Just a thought that if you all did restart those, it could be offered as like a voluntary integrated assessment. So it would align with that,
Yeah, we're a little bit different. I know some states have the luxury of being able to look at policies, and they might go in and say, what do you do with your infectious disease material or things like that. Our inspections in Maine are, we go in, we inspect the ambulance and look at the equipment that's on the ambulance and that it's serviceable, and that's where it ends. Everything else is electronically submitted, like QI plans or things like that might be required, but we don't go through and inspect paperwork or procedures or anything like that. I'm envious of states that have the ability to do so, but I guess I'm just, I'm not trying to be obstructionist to this. I'm trying to function within the bookends that I have for resources and, what is achievable.
Yeah. Well, I do know virtual is allowable, and even a follow-up call to say, thanks for submitting your application. I just like to run through it with you to ask a few questions. That could be something maybe that you could incorporate.
Evan or Eric, and I'm jumping around on the questions in the chat. So you said we are currently doing virtual visits using video inspections. What does that look like? Can you describe that?
Yeah, of course. So that's for our ED inspection program. But we started doing virtual site visits in 2020. And so we've been kind of fine-tuning and tweaking it since then. And obviously we still have a ways to go as well. But that's worked really well for us. It's easier for our review team who's going in and inspecting the hospitals or the policies and procedures, because they don't have to commute all over the state. And it's eased the burden on our internal team as well. Like I said, we just don't have to do as much travel. So that's worked for us. And what we ask for the hospitals to do is to submit any of their documents or any of the criteria that we're looking at prior to the site visit, so that we're able to inspect that beforehand, and the actual virtual visit is more of just getting context for those policies and things that were uploaded. And this is in Arizona.
Thank you. Is anyone on the call implementing and developing, maybe not implementing, but developing the process both for ED recognition programs and pre-hospital programs at the same time?
Julie, this is Cindy from Maryland, and we thought we were going to do that, and then we realized we were going to have the National Pre-Hospital Pediatric Readiness process and decided to wait. So we're continuing to sort of build the infrastructure. We've held 2 meetings with our champions to talk about what that might look like. I will tell you the champions criteria for what an EMS pediatric recognition program should look like is much higher than what we just looked at on your screens. But that has not been to their EMS chiefs or their fire chiefs. It is their aspirations. And of course, these are the people who stood up and said, yeah, I'll do one more thing for free. But it really seemed out of sequence to create a standard before we knew what baseline was. So as soon as we can have aggregate data as well as detailed data, and that very detailed Excel spreadsheet that EDC sends each state manager, we will then look for common themes, compare them to what other states are doing, and then start. So we anticipate a conversation late fall and then drafting criteria in the spring of 25.
And that's for your EMS program?
Yes.
Okay. Yes. Phyllis, are you doing that in Florida? Is that why you asked that question?
Well, it's just a lot if you're in a big state to be doing both programs and visits. So we have made more progress on our EMS pediatric readiness recognition. We've determined 2 levels. It's been to the advisory board. I just have to tweak a few things, and then Caitlin will, we'll send it to HRSA for approval. We'll definitely have to do virtual visits. And we just have a lot more buy-in from EMS. It's, we can get in touch with everyone. Our hospitals, it's hard to even find out who to get in touch with. So, and we had some legislation that was pending regarding requiring EDs to have certain things for pediatrics because of the Wall Street Journal article. So we were waiting to see if that legislation passed, and it did not. So, we've made more progress on EMS than we have on the ED side, but it's a lot to balance both of those. And so they're both performance measures for our grant. So I think I feel better knowing that, most people seem like they're in the same boat we are. You almost have to choose one or the other to focus on.
And even planning this collaborative, last year we talked about this. Will states try to do both at the same time? And we had conversations back and forth. So. All right. So last month we've been talking about the minimum criteria. We've come to consensus. So last month we talked about maybe talking today the verification process of the criteria. And we started to get to this towards the end of our criteria conversation. Pull this back up. As far as, Emily asked, what does assessed mean, and how do we look at that? And of course, it's going to be state specific. You are going to come up with your own process. But I thought maybe we could ask, we'll again start with Nicolena, and then maybe talk about a few other criteria that you have questions about. What does that look like in the verification? How would you verify X? And so, Nicolena, will you speak to, you may not have all of the minimum criteria that we came to consensus on, but will you speak to some of the verification, how you verify the criteria that you do have? And you don't have to cover all the criteria you have. I know you've got quite a few things but maybe pick out the ones that are a little more difficult, that are challenging, and speak to those.
Right. So we have two levels in Colorado, pediatric prepared and pediatric advanced. And the main difference between those two levels is the presence of a physician PEC. And that was identified in our steering committee as a prohibition for a lot of facilities to be able to become verified because they rely on locums physicians. So the main difference is that presence of the physician PEC, and then therefore some of the areas that pertain to it, such as the layers of the QI process. We have a minimum requirement for pediatric QI for all facilities, but then those extra layers, if you don't have a physician, it's a little bit harder. And so what we rely upon when we have an applicant is their own self-reporting. And I think that goes to Mark's point earlier, is there's a certain level of trust that you have with these facilities that they are reporting accurately, that they're testifying that yes, that we have all of these things in place. We have started asking for some policies, because that's been a little trickier for us to verify. And that came up in a conversation recently when a facility reached out and said, do I really have to have a pediatric disaster plan? Or do I really have to specifically include kids? And we said, yes, that is the minimum, one of our minimum criteria. And we also had a different facility, which if we hadn't been there having a conversation with them, we probably wouldn't have realized that their interpretation of the checklist was a little different than ours. And so we were able to tease out what it actually was they were doing. So when we have our site visit, it is really a back and forth conversation with the facility where they present on, we ask them to present on a few things like their education, their QI process, what this whole process looked like to them. And then based on what we've seen on the checklist and a sense of what we're getting during that presentation, the conversation, we start to ask more targeted questions. One thing that has come up that we've started realizing that we need to push a little harder on is, and this goes to the equipment. I don't want to get into verifying each piece of equipment, but we're finding facilities have radically outdated Broslow tapes. So that's one of the questions that comes up during that back and forth. Hey, what's the expiration date on your Broslow tapes? And if they say, oh man, we don't know, or if we're walking through the ER and we see that it's expired, we include that in the letter of recommendation that follows up. We have not yet had a facility not become verified after a site visit, but I imagine there might be a time when we say, hey, at this time we can't verify you, but here's our recommendations. This is what we offer you as a plan of correction. And if you want to go forward with that, we would love to talk to you about after you get that done, come back to us. But a lot of this is just relying on facilities' goodwill to report honestly and our ability to ask questions during that verification site visit where it's a back and forth. So disaster plans, I think, has been the hardest because they can be pretty widespread. You can have an annex or you can include kids throughout your disaster plan. So I'll say that's been really helpful to be able to talk to emergency managers, to be able to tease some of that nuance out of disaster plans and what they've done to update. Medication safety, I think, has been a bit of a challenge, especially some of our very small facilities that just don't see kids, trying to tease out what they're actually using for medication safety. I spoke with a facility recently who, after the course of the conversation, we realized that their staff were using 4 different volume-based dosing tools depending on their preference. And we were able to help them identify that the reason is that they didn't have single source sign-on for their computers. So the medication safety tool required them to sign on in a secondary way, which if you're coding a kid, that's not a time to do it. So now they've worked with their IT team and corrected that. So I think disaster plans, what is the actual volume-based dosing plan? Are people using it? Those kinds of things. And then I think we're starting to troubleshoot, how do we help facilities stay pediatric ready with employment turnover?
That's a big one, definitely.
But again, I think this goes back to what Mark was saying, is that being a trusted partner, that these folks, we're trusting them to report accurately and correctly. And that we're just asking some strategic questions to try to tease out if that's where they're at. And then provide them with the tools to be ready. It's not about catching them in the wrong. It's about giving them the things that they need to cross the finish line.
Like that. What about our pre-hospital programs? How are you verifying virtually or in person? We want to hear from both. How are you verifying the criteria, especially the challenging ones? So one of our minimum criteria that we came to consensus on is using a standardized weight estimation system. Does anybody have that as a criteria now? Don't be shy. We're helping each other. We're learning from each other.
Hi, this is Eric from New Jersey. We have standardized weight criteria in our volunteer program.
And how do you verify that?
Yeah, that's the challenge. So yeah, they basically just have an acknowledgement that this is what they do. And then we have the ability to go out there and randomly check if we want. So I guess we would have to look at their charts and their documentation and see that they're doing it. But their policies have to say that they, record weights in kilograms and everything like that. So.
Okay. Policies. Mark, how do you, I'm gonna come back to you because you were saying that you're hesitant to go out in person. Do you do virtual verification or how do you ask them? So, that trust issue or not trust issue, but that trust that you have in your physicians and you give that to them. Is Mark still on the call?
I am.
Okay.
There's-
So
I
how
need
do
to
you
finish the
ask
question.
them and get them to tell you yes or no?
They complete the required survey that we base all the studies and evidence on. We trust that they fill those surveys out correctly. So why would they be lying about that? And I guess my virtual visits are not like walk around with an iPad or anything like that. My virtual visit is, hi, Dr. So-and-so, I'm Mark, and how can I help you with this process? And so it's more of a meeting about this. And if they have questions about the forms or the process, they do a gap analysis based off them completing the survey. All the hospitals that have been recognized in my state have redone the survey because the last one was so long ago and it was in the middle of COVID in a different world. So they're updating it and staff changes and resource changes. So they feel that redoing it gives a more accurate measurement. So then they go through and work within their own hospital team and come up with a gap plan that is at a rate that's comfortable financially and staffing wise for that hospital to achieve. And they submit a copy of that to me. And that's pretty much what I do with them. At the end of the day, this is a voluntary program. For me, a different division of my state licenses hospitals, so I have to balance delicately, not overstepping my bounds with that. And so I trust when they submit that. I don't think they have any reason to lie. You know, getting achievement or getting recognized doesn't mean they can bill at a higher rate. It doesn't mean they can accept different patients. We're still going to bring pediatric patients to them, whether they have this recognition or not. There's nothing in our protocols that would discourage someone to go to it. So there's no motivation financially or performance wise. This is a voluntary program that basically comes from the heart of people that are passionate about taking care of children and improving that. So I don't see any reason why they'd be falsifying information. So that's what I base it on.
Yes. Okay, so we have a few more minutes. I have another question for Nicolena and everybody. But before we move on off of this, I want to give y'all one more chance. Are there any criteria that is anybody struggling with on how to verify virtually or in person that you would like to ask? We're all here, we're learning from each other. So are there any criteria that you would like to know, hey, I'm having trouble with this. How do others do this? Okay. If you think of something, let us know. We can circulate something. So Nicolena, one more question for you. How are you tracking data? You said something about a red cap survey, but I don't know if that has this, but how are you tracking data when you receive it during the application and or the verification process?
So we use REDCap. You know, we're associated with the School of Medicine, so we have access to REDCap, but I think you could use Microsoft Forms to create your application and checklist for digital submission. We did have one facility who was struggling with the REDCap, and so they just printed off the printable version of it and checked everything off and then, you know, scanned and sent it to us. I use a lot of spreadsheets to track dates and when an application or a checklist was submitted, any issues we're running into, in part because that's just how my mind works, but it also kind of helps me track, you know, the different areas that people are reaching out about. I've also recently become a user of Microsoft Planner, the tool Microsoft Planner. It's not great, and it is definitely not a very sexy tool, but it is a functional tool for me. Essentially, it's a project management software tool. And if you'll let me share my screen, I can show you what I've been doing in there. Just for folks to kind of see, because I was losing track of people. I was losing track of where we were in the process for folks. So essentially what I did is, so this is Microsoft Planner. There's better versions of software out there. So this is not a, you know, plug for them. It's just what we have access to. And so I created a template of all the things that I reach out to our facility for when they're doing their pediatric readiness. And so did they fill out the application, the checklist? And then I do a monthly follow-up communication to all of my hospitals that are in process. And so essentially what I do is in Outlook, I create a signature that is titled by the month. And it's like July Copper check-in. Copper is the name of our program. And it essentially has blank fields in there, but it's the same stock email. And in the scheduler, it just offers me up, well, you can see I'm behind on a follow-up email, but essentially like, so I need to follow up with San Luis Valley Health on the 19th. I send them the stock July email. I just add in Julie's name and I add in San Luis Valley Health and hit send. And then I check it off, and that just helps me track my communications and what I've communicated about. And then post follow, you know, there's some stuff that we send when we do the site visit, like I try to get them all on the NPR QI program. I have a pre-site meeting with them. I, you know, schedule a site visit, send them a letter saying who's coming, send the site visit letter saying, congratulations, you've been verified. These are the things that we liked. Here's your suggestions. If there's any reimbursements that I need to submit, I include them here. I update our website so that we have the facility listed. I update CLEMS because there's some PEC or the facility stuff. And then all the marketing stuff, so on and so forth. And then I just copy this over into each of those facilities. It's pretty straightforward. It's pretty easy. I will tell you, if you use project management software to set up anything to try to help track where you're at, plan on it taking a couple days. Like just know that it's gonna, for lack of a better term, it's just gonna suck and you just gotta do it. But man, once this is up, it has really expedited everything that I do. It really has helped me stay on top of things. I mean, as you can see in that calendar, you know, all my monthly communications are there. It probably takes me 10 minutes a day to communicate with my 28 hospitals that are in process. And that's if I'm, you know, dawdling. It's usually like a 3-minute process to send out that email, check it off, and I'm done. And I know I've got it covered. So, you know, whatever works for you, I think is the thing that you should do, whether it's an Outlook spreadsheet or you're really good at pivot tables. I'd love to be friends with you because I can't figure this out yet. So on and so forth. But, you know, whatever works for you, I'd recommend you be consistent across each facility because that, you know, there's a lot of information that says someone's response to you is predicated upon the previous interaction. And so if you are good about following up quickly, they will be timely with their communications and their responses tend to be metered. So I just try to stay on top of it and not let it get caught up because, you know, a couple months ago I had pneumonia and was way sicker than I thought and my communications fell off and it just turned into a total goat rodeo. Once I got it back under control, it was fine. That's when I set up the project management, but I was just relying on my, you know, stubbornness to get this done. I highly recommend some kind of project management or some kind of spreadsheet. The nice thing about Planner is you can assign it to other people as well. So, and then, you know, you can also give access to other projects, which is great. So, you know, next time I hopefully never get that sick again, but my project manager has access to it. My colleague has access to it. They can step in and take over. If I ever leave the program, all that data lives in one place.
Nice. So Microsoft Planner, we heard a couple months ago about Smartsheet, and that was part of this conversation. And then somebody else, Rachel, you said that you've got Smartsheet, and then somebody else said an Excel spreadsheet. Are there any others? Software, or are you writing it down? Are there any tips or tricks as far as keeping track of all this information? Okay. Okay. Well, we are at the top of the hour. As a reminder, you will be receiving an email as a follow-up, and it will outline the next 5 months, the next 5 sessions, and we'll have you sign up to report out on your state's recognition program and where you are. We'll have the slide deck ready for you so you can just kind of fill that in. But if you have any questions, don't hesitate to reach out. And Nicolena, thank you again for all of your great insight, and thank you to everybody for chiming in and sharing your best practices. Have a wonderful day.